to grips with WebEx. I think, can everyone see that presentation okay?
Yeah, that's come up fine, Tony. Just needs
Real.
to, yeah.
I think I picked the slowest laptop I could today. So welcome everybody. My name's Tony Cosgrove. I'm a physician associate in Hough. I work specifically in the specialist complex rehabilitation unit, which is Ward C1, complex rehab. I'm also a physician associate graduate tutor and a module lead at the York Medical School on the physician associate program. So what I want to do today is just kind of give a quick overview. Brain injury is an absolutely massive topic, and it's something I can't do justice to in under an hour. So what I want to do is give you a bit of background on what rehabilitation is in the context of brain injury, our NDT and what disciplines make up the NDT and who feeds into brain injury rehabilitation, give the overview on brain injury itself, and use a case to set the context and to help direct a bit of teaching around it. And then we'll bring it all together and summarize. So who are specialist rehab? Well, we're based at Castle Hill, Ward 1. We've got our lovely new unit. So I've put our artist's impression. We are in it now, but it's not been the best day to take a new picture for it. We've got 12 beds, 8 cubicles and 2 dual occupancy bays. We take secondary care referrals only, and we require that patients come from a Humber or East Yorkshire GP. And unfortunately, Goole does not count in that because they're swept up by NLAG and they have their own very swanky rehabilitation unit in Goole. But we do repatriate patients, so patients with those local GPs who have been injured out of area can come back to us. Why have I mentioned what makes our bed state up? Well, one of the things we're very fortunate with is having 8 cubicles is very important in brain injury. Placing patients into a low stimulation environment and managing that stimulation, ensuring that the patients, if they become agitated, are separated from other individuals who they could harm or do harm to themselves. We have an acute rehab team that's made up of one of our consultants, one of our senior OTs, and our registrar. I sometimes get involved as well. It's all about going out there, finding the patients, beginning a rehab plan with the patients when they've been identified, and then getting them onto the ward. And we're also allied to the amputee service. So our other consultant works with the amputee service. He's the consultant lead for them. So a bit of a diagram. Everybody's circle is the same size because in rehab, all of these disciplines, we all have a pretty equal part to play. And I think we're going to go through each one of these in turn, but I think unlike most other places, nursing and medicine on rehab is very much a backseat approach. We take patients who have become medically stable because they need to be medically stable, ready and fit to commence their rehab in order to get the most out of the process. Really, the decisions that are made in the medical team are around fitness for discharge or fitness to admit to us and what kind of pharmacological interventions or optimizations we can make. Physiotherapy, one of our top therapy teams that we've got in here, they focus on maximizing patients' range of movement, whether that be passive or active. It's about progressing patients to independence in their mobility as possible, working from initial transfers to stepping, walking with walking aids, and then becoming independent. It's about safety, getting patients used to using mobility aids, training family to use mobility aids, making sure that people have realistic expectations about what they're doing, acquiring that mobility equipment when the time comes for a patient to go home, and then organising any community interventions that are needed through ICT. Our OTs, they work on decision making. It's direct measurement of deficit. So we've got specific tests that we use in brain injury. So I'll come on to post-traumatic amnesia in a bit, but for measuring post-traumatic amnesia, we have the Westmead score. For direct measurement of deficits, we use MOCAs more often than not, or R-bands, which is a specific brain injury testing score. That is to say, in all of these tests, what we're looking for are higher executive function deficits in these patients and quantifying in a way that allows us to chart progress. It's about holistic measurement, not only just giving patients tests and papers and getting them to answer questions for us, but also testing their performance in structured tasks. Some patients may do very, very well on paper, but for those individuals who have an issue of splitting attention, when you present them with a kitchen assessment and ask them to make a cup of tea whilst also making breakfast, it can all fall apart. So it's about finding these areas where support can be implemented for the patients and making sure that really when they come to leaving, it's a safe environment for them. Again, it's about acquiring equipment. So in this sense, modifying the home environment, organising home and access visits, potentially looking at weekend leave for patients so they get a road test of what it's like going home, and organising cares. Our psychology team are brilliant. They come in 4 days a week. They're really important in brain injury patients. I think that the big takeaway from this is that brain injury is not just life altering, but the majority of the circumstances or the majority of the modalities of brain injury are catastrophic, and it can cause patients to become emotionally dysregulated, particularly patients who have a history of low mood. So it's not just a talking therapy, but it's about that emotional management and building emotional intelligence in these patients, managing their insight, and it's a long-term intervention that we offer. So it starts as inpatient, but it progresses to outpatient. And don't forget, brain injury doesn't just affect the individual patient, it also affects the family around them. If there are changes that need to be made, some families might not be prepared for the changes that will come. SLT, so not just swallowing and speech, but looking at composition, recognition, clarity and verbalization, how the patients are swallowing, they investigate, re-educate, make decisions and recommendations on diets, diets and fluids. And social services, not always everyone's best friends, particularly the patients, but they make pragmatic decisions with regards to where patients will be placed. Their goals centre around adequate care for patients and identifying suitable nursing environments in our area, local to the patient. It can come secondary sometimes, but within the Hull and East Yorkshire area is a priority. So now we've gone through all of the allied teams that help us in delivering this rehab. Just a really brief diagrammatic overview. So all brain injuries are acquired brain injuries, ABI for short, but we can subdivide that and then we can subdivide it further. So going down the left-hand side, traumatic brain injuries are those where there's a physical cause of injury. For example, patient has been involved in an RTA, has sustained a traumatic subarachnoid hemorrhage, traumatic subdural hemorrhage, an extradural hemorrhage. The small t's there are just traumatic as the prefix. DAI, diffuse axonal injury, which I'll come on to in a little bit, and cerebral contusions, so small areas of vascular compromise in the brain caused by direct trauma. Non-traumatic brain injury, that's really a physiological cause, much wider umbrella this. So it could be anoxic or hypoxic brain injury. Anoxic brain injury caused secondary to a VF out of hospital arrest. Hypoxic, potential patient has attempted to end their own life using a ligature. Metabolic patients in taking an overdose or ischemic hemorrhagic, spontaneous subarachnoid hemorrhages, or the unfortunate patients who can have spontaneous subdural hemorrhages. So I think the big point for this is location of the injury is largely predictive of the deficit. Traumatic brain injuries are most likely to be local, particularly contusions, penetrating trauma. You can draw a line and say this is exactly where it's going to be, but your traumatic subdural, subarach, extradural, and diffuse axonal injuries, your more widespread injuries, have quite global effects. Your acquired brain injuries, well, it really depends on the mechanism. There are stroke physicians who can look at a patient, do a 3-minute neuro exam, and pinpoint exactly where that lesion is. You can have a patient who has had an anoxic brain injury who has a global deficit, and we often see that. Stroke doesn't come under our pathway. I thought it just bears to mention that the stroke pathway and the stroke rehab pathway falls under its own pathway. So I won't be touching on stroke today. So just some stats for you. So on the left-hand side, this is data that's been taken from Headway, who are the lead head injury charity in the UK. Unfortunately, since 2005, head injury rates are up 1%. It has fluctuated, but since this data was published in 2016, it's our most recent set of data from this charity. Head injuries were up 1%. All acquired brain injuries, so that's everything, including strokes and traumatic brain injuries. There are 348,000 per year, and again, that number is increasing. But what you'll notice on this bottom left-hand side is that men are more likely than women to sustain a head injury at 1.5 times the rate, but women are beginning to catch up. So whilst traumatic head injuries make up a minority of the admissions, they make up a massive complexity of the admissions that come in through the doors of rehab units across the home nations. So let's get into our case. So this is the case we're going to use to kind of set the scene and do a bit of teaching off the back of. So this is a 58-year-old chap who was out walking on Scafell Pike. He ended up falling 50 feet, witnessed by his son, into a rocky crevasse. Unfortunately, because of where it happened, and it happened in the middle of lockdown, when they probably shouldn't have been walking on such a precarious rock, it was very, very difficult for him to be extricated from that crevasse. So it was very traumatic for the son, as you can imagine. It was just them two out there. The son managed to get help, and he managed to be extracted after 3 hours. So he was airlifted to Royal Preston Hospital. En route, he was sedated. Non-invasive ventilation started. When he got there, he was, on the initial scans, found to have a traumatic left subdural hemorrhage, a traumatic subarachnoid hemorrhage. We'll get into the diffuse axonal injury later, but at that time it was presumed to be diffuse contusional injury to the brain. As a result, he had a right frontal craniotomy for a bone fragment removal because he had a collapsed skull on the right-hand side. He had a 34-day ICU admission, and he had 3 sedation holds while he was in there. So you can imagine those first 2 didn't go so well for this patient. On the 3rd hold, he began to wake slowly, but that's when they documented the first seizures on ICU and started Keppra levetiracetam. So after his 34 days, he was stepped down to neurosurgery, and he was found to be sedate and non-verbal, bedbound, not moving, not responding to the nurses. So a decision was made to try and find a rehab unit for him. So this chap had a East Yorkshire GP, so he was able to be repatriated to us. So I'll come back to that patient in a minute. So traumatic subarachnoid hemorrhages. So these are subarachnoid hemorrhages that occur in the context of trauma. So I'll let you have a quick look at that CT scan on the right-hand side, and before I get to it, see if you can see where the bleed is. So it presents with agitation and potentially loss of consciousness, but most patients that come in with traumatic subarachs are conscious at the time and agitated. Can you see it? It's normally imaged in the sulci, so generally it arises adjacent to fractures or contusions and contusional injury. But in this patient, we have a coupe contra coupe phenomenon. So the bleed itself is just here, but from this edema on this side, this is where the patient sustained the trauma. So what's happened is, as they've had the trauma on this right-hand side, it's passed along. The brain within the skull vault has hit the opposite side of the cranium, causing that bleed and extravasation on the opposite side to the initial trauma. So really, they're quite broad. The hypothesis of how a traumatic subarach actually matures and how it actually bleeds. The top hypothesis is that it's direct extravasation. There's a shearing force on the vessels that causes, through arterial venous trauma, a vascular dissection that causes a bleed in the sulci. But I think at the bottom in red, one of the things to bear in mind is, particularly if you have a patient with a brain injury, you see them in ED or you see them a bit later on down the line, ask yourself, was it witnessed and was it truly traumatic? The patient who has come in with an RTA, if the patient has had a spontaneous subarachnoid hemorrhage which caused them to roll the car, it's different to the patient who's obviously driven their car into the tree and then sustained the traumatic subarachnoid hemorrhage. So traumatic subdurals, I'm sure that everyone here is pretty familiar with subdurals, so I won't really go into too much detail with them, but they make up 15% of all traumatic brain injuries. Commonly, patients will come in with altered levels of consciousness. In adults, they are generally unilateral and arise adjacent to the fractural contusions, but in young people, unfortunately, particularly children who've sustained non-accidental injury, they are bilateral in nature. Treatment depends primarily on the mass effects and deficits. So on this CT here, we can see that there's quite a massive mass effect. There's ventricular compromise. That patient would most likely need a burr hole and drainage. And we can see it's still in the acute phase at the moment. So everyone knows, be aware of the coagulated patient, but one of the things about rehab is taking calculated risks. So we have many patients with brain injury who are unsteady on their feet, who I would guess on most wards probably wouldn't be allowed to get up and wander around under the watchful eye of the physios, I might add. But with rehab, it's about taking calculated risks and ensuring that what you do to get that patient back to baseline is done under a watchful eye and as safe as possible. I actually cannot remember the last time we had a patient fall in physio. I think we might be reaching back well over about 4, maybe 5 months. The physios are brilliant at keeping on top of the patients. And then at the bottom, another takeaway point. So as we can see here on this right-hand side, you've got a patient who has a concave bleed. So I always think bananas and lemons. So concave banana within the brain along the inside of that cranium, that's a subdural. And then if it's an extradural hemorrhage, it's convex. Yep. Now I'm getting concave and convex mixed up, but always thinking bananas and lemons. So diffuse axonal injury, I promised that I'd come back to this one. So this is best imaged on an MRI. One of the things to note about this is that there's a lot of crossover between your patient with a traumatic subarach, but importantly, your patients who sustained a diffuse axonal injury will almost exclusively lose consciousness at the scene. So it's in the name. We can have a look at these MRIs. Diffuse axonal injury, it's a widespread and global spread of contusional lesions throughout the brain that leads to grey and white matter loss. In these MRI is the best way to image it. In these MRIs, if we have a look here on this temporal lobe, I'm not sure if you'd be able to see it on your screens, but there's quite marked contusional activity here, and a bit further up on here. There's some mild changes on this side, but predominantly this area. So when it affects multiple lobes from the same shearing forces, and it's undifferentiated between white and grey matter, it's a diffuse axonal injury. So Again, it's something that matures over time. It's something that can, in a sense, be a clinical diagnosis. The patient has a prolonged post-traumatic coma, fails to wake, fails to respond sufficiently to the sedation holds, and therefore is likely to have one, but you will see it on imaging. It results from the shearing forces and deceleration. In a coup contra coup injury, the brain will hit the opposite side of the skull vault and will sustain an injury on that side. With a diffuse axonal injury, it's like rattling a ball. The brain will continue to move in the skull multiple times, causing widespread damage. And as I say, it's generalized spread. So just the take-home point at the bottom, it's not something that can be imaged in the acute stage. It's likely to come up in your ICU serial MRI imaging and progress checks. So how do we prognosticate? We've talked a little bit about how our patient was doing and failing with those sedation holds, and we've also talked a bit about the post-traumatic coma in diffuse axonal injury. But key to us and what we're looking at in brain injury to chart how well or what kind of prognosis we may give our patients. We look initially at ICU stay, so rapidity of waking, how well they perform on sedation holds. Post-traumatic amnesia, as we touched on earlier, so that is an antegrade amnesia in these patients. They fail to be able to generate memories after the event. They fail to recall the event, but most importantly, they fail to understand the events that have happened since they've been in hospital. So really, to measure that, it's done using what's called the Westmead scale. It's a score of 12 out of 12 that they need to pass. And you need to score for 3 consecutive sessions at 12 out of 12 to be classed as out of post-traumatic amnesia. But your patient, as you can imagine, needs to be alert and capable of answering questions. For both post-traumatic amnesia and post-acquired brain injury cognitive impairment, we give an arbitrary window of 12 weeks for patients to regain a level of baseline. This is evidence-backed, although it's particularly shaky, because as you can imagine, that patients are highly individual, and there are a number of factors that can contribute to how well a patient will interact and buy into the therapies surrounding the measurements that we use. So in an ideal circumstance, if we're measuring a patient's post-traumatic amnesia, cognitive impairment, we would hope that they would be classed as out of both by 3 months. Otherwise, the prognosis for cognitive, for reaching their cognitive baseline is very, very poor. So previous injuries, if a patient's had any previous bleeds or if they've had any previous comorbidities, the concept of neuroplasticity is key. So with the brain, unlike other organs, when part of the brain sustains an injury and dies, unfortunately that area is gone forever. So neuroplasticity is the theory that areas within the brain can compensate, particularly the opposite hemisphere, to pick up the slack of that area. So individuals who've had previous injuries and have sustained a new traumatic brain injury are likely to have a compounding effect and therefore a reduced ability to reach their baseline. Because of the concept of neuroplasticity, there's less grey matter for them to be able to recover. We have to look at comorbidities, addictions, and mental health. Unfortunately, we're seeing a lot more of the addiction side coming through, particularly following COVID-19. Patients with a lot of comorbidities, it can be difficult to generate actionable rehab plans for individuals who are unstable in their comorbidities. Patients with addictions, it's discharge planning that's most difficult, but particularly individuals where you're managing pharmacologically addiction as well as pharmacologically managing their presentation. And mental health, I think I'll come on to mention that our chap has low mood, so we'll go into that shortly. And then also the patient's own baseline. We can't likely expect ourselves to rehab a patient beyond how good they were before they came in. But we also need to know whether we're setting our sights too low. So we need to understand where our patient has come from, the life they led before they came in, and what we can realistically aim for. So going back to our case, so a bit about him. So he was an archivist by trade. He was a well-respected historian, highly intellectual. He had about 3 undergraduate degrees and 2 postgraduate degrees in history. His family told us that as a baseline, he's pleasant, he's kind, he's quiet, he's loving. We found out that he was a druid, and he was a practicing druid. And as a result of that, he was staunchly anti-Wiccan, and it was a wake-up call for me because I had no idea about any of these things until I met this patient. And he was a writer of erotic literature in his spare time, and that's something his family didn't know about, but we'll come back to that. So comorbidities, he was a relatively healthy guy, and he was going out for his hike when this happened. So you can imagine he was quite active. So he had hypertension, but he wasn't taking anything for it, and he did have a low mood prior to coming into hospital. That was related to being asked to reduce his hours on his main job in being a local historian. So stepping back, looking at what we think might be a rehab journey for a patient. So I've plotted on this left-hand side on the y-axis patient initial injury and then to achieving baseline. On the x-axis time, not putting any specific markers on it, but just working a bit flexibly with those points. So after the patient has had their injury, regardless of what we see, there is some level of improvement in these patients, so long as we see them beginning to wake. So in that initial phase, you have the post-injury management in the post-injury phase. At that point, the patient might begin to do a bit better. The base ward sees that this brain injury patient has a bit of potential. Maybe neurosurgery is a bit too busy for them. Maybe they could do with some more specialist MDT input. So at this point, we'll say perhaps they call in the acute rehab team and then we take them. So the patient comes to us, they start to do pretty well, the progress picks up, and then like everybody, they've started to adjust to the new environment, they begin to plateau. And you can plateau for a number of reasons. Sometimes it's the patient's injury. We need to become more creative with the way that we address their deficits. For some patients, they are less likely to be involved in their therapies as time goes on. As insight builds, sometimes patients can disengage because they think their baseline or their current level of action is better than the silly tests that we're giving them. If you're asking patients to repeat after you or to remember words and give them back to you, sometimes patients can find them quite infantile. So let's say this patient has come to this point and they've started to feel a bit upset by what we're doing. They feel as if we're not really doing much for them. We get to this trough here and we get psychology in, and psychology come in, they explain what's going on, family begin to buy in. Not only is the patient being motivated, but family are being motivated. It's all building up. And then the patient gets a UTI, but we treat that. And then we get to this point. Now, I think importantly, we don't get the patient to baseline in hospital because we'd be hanging on to patients for too long if we did that. We have to be confident we've given the patient the tools to get better at home or get better in the next environment they move to. So we'll set the discharge just a bit before, but at a point where we're confident that not only are they going to continue to recover, but that they're going to be safe as well. A bit more about baseline. So like we said before, we have to establish a pre-morbid baseline. It not only tells us about the function pre-morbidly, what they did, how they did it, did they have a job, did they have something to go back to, but also what difficulties they may have already had. For some of these patients, particularly individuals who didn't engage in their education at a young age, there's no point giving them mental arithmetic and deficit measurements such as the R bands for brain injury, because they may not have a grasp of mental arithmetic as a baseline. So what we do is we bring family in, We use the baselines as an opportunity to manage expectations, to say, look, they're not going to come out as the brain of Britain when they leave, but we need to make sure that they're getting to where they're going to be, where we hope that they will achieve their pre-morbid baseline. And don't forget that we've been through a massive lockdown period where some family might have been shielding. These patients could have been in hospital for a month or 2 months before they even come to us. So next of kin might not have even seen these family members for over a year. And now they've come and seen them. They're shocked that they have a brain injury now. And they might not know what their baseline was during that year. So it's important as well to know the baseline for goal setting meetings. We do goal setting meetings every 2 weeks with our patients where we progress check, we make sure that they're on target, and then we can continue to show them how we will augment their function. They then progress to discharge planning meetings as we come to the end. So going back to our case, so he came back to Hull at 56 days post-injury. So he spent a further, I believe it's 20 days on the neurosurgery unit at Royal Preston Hospital. He was still sedate at that time. We had a look at the notes and they said that, pardon me, he remained very sedate, bedbound, didn't move. Well, we found immediately it was a very different story. So thankfully we managed to get him into a single occupancy cubicle. He was immediately mobile, he was unsteady on his feet, he was not ready to be walking around, and he was impulsive in what he was doing. He was beginning to, when he wanted to do something, he would switch his attention immediately, run towards what he needed to do. He had a fascination with writing letters, and he would write us all letters about the smallest thing that had happened on the ward that day. And he'd be very impulsive about mobilizing at the last second. He was loud, he was disruptive, he was disorientated in time and place, but he was orientated to person. And he had psychotic disturbances that were noted. And he became quite verbally and physically abusive towards female staff within those first few hours of landing on our ward. So the first things that we did, we filled out a DOLS, deprivation of liberty safeguarding form, and that gave us an opportunity to put a one-to-one in place. So at all times, there was an auxiliary nurse that was with him, that was managing him and keeping an eye to make sure that he didn't harm himself or others. We got a head guard in because whilst he was bedbound, the neurosurgery team didn't give him a head guard. We thought if we can't stop him from getting up, because sometimes he will be too quick, we'll get a rugby head guard for him, which was made by our lovely orthotics department and got that fitted. Lorazepam to get on top of the agitation. And an EEG, we knew that he'd had seizure activity previously, but we needed to know if seizure activity had been contributing to this current picture. And that's something that is very common in brain injury patients, particularly in the post-acute stage, where focal seizure activity continues to feed into an agitated behavior, an agitated state. So we're going to have a look at relating anatomy. So on the right hand side, I think really rather than going into all the neuroanatomy because it is such a massive discipline, we're just going to stick to the 4 lobes of function. So the 4 lobes that govern the higher order functions, the functions that make you and I us and help us organize our thought and our processes, and how their function relates to deficits that are seen in these patients. I'm not sure if everyone here knows, but this chap down here is a chap called Phineas Gage, who was a railway worker back in the 19th century. You can see from this recreation on this skull, he was working on the railroads one day. His family said that as baseline, he was lovely, pleasant, family man, family orientated and caring. He managed to unfortunately sustain a railroad spike through the eye, and it went through his frontal lobe, which caused a huge personality shift in this guy. He became a gambler, a drunk, and was getting into fights all over town. I believe his life ended one night after he had a skinful of alcohol and started on the wrong person. So frontal lobe injuries, have a read of these on the right hand side at your own leisure. They're just an overview as to what kind of functions these lobes perform, but most importantly, the executive functioning of the frontal lobe. If it's affected and if it's injured, you'll see behaviors of agitation, disinhibition, paranoia, inattention. Patients will become physical, potentially fighting, and patients will fail to regulate their emotion. Parietal lobe injuries. So your parietal lobe injuries here can cause loss of orientation, failures in sequencing tasks. We can have patients who will put their trousers on and put their boxers on top, patients who've put their hands into shoes, gloves on their feet. It focuses on the basic sequencing of everyday tasks. It can cause visuospatial abnormality, patients who fail to perceive depth, and again, attention deficits. Visual cortex, as you can imagine, it's in the name, but really it's about, in the occipital lobe, making sense of the world around you, analyzing the images that you see and abstracting meaning from those images. And then finally, temporal lobe effects. It's responsible for auditory processing and understanding, but also storing factual information, and particularly patients with temporal lobe abnormalities may suffer a retrograde amnesia, but most likely these are your patients who are in PTA, post-traumatic amnesia. They fail to create new memories. They have an anterograde amnesia because it's involved in memory formation. So going back to our case, so the EEG confirmed focal seizures. So we switched Keppra. Keppra is really, really popular with neurosurgery. It keeps your patient sedated as a secondary effect. So we switched it to sodium valproate, helped him wake up a little bit. Sometimes you can find in the brain injured patient that sedation and feeling sedate can often cause them to rail against it and become more agitated as a result. We commenced risperidone for the psychotic episodes and behavioural management. And one of the things we noticed was that despite all this, the patient appears to be persisting with the visual and auditory abnormalities. So we had a bit of a listen to what was going on, and it turns out that, as I mentioned earlier, this patient was an author. They had, in fact, mixed their reality with their own literature and their own religious beliefs. So he believed that all the nurses were witches that were bubbling up all these drugs that were being pushed into him, and it was making him very, very unhappy. So he became very, very agitated about that. And it became difficult for us to attempt to get around that, because when a patient presents with a false fixed belief, something that's well documented in psychiatry, but much, much more difficult to address when you have a brain injured patient who lacks the attention and lacks the ability to form new memories around this, you will find every day you go in and you're retreading the same patterns with the patient, attempting to get them on track. The agitation itself is multifactorial. Like we say, sometimes patients can become quite upset that they aren't able to form new memories, upset that they see new people every day, even if they're not. I'm sure everyone knows it's similar to the patient with dementia who is unable to confirm what's going on. UTIs, blocked catheters, contracture, spasm, pain. If your patient's non-verbal, you may have organic causes. But don't forget the EEG. Be wary of the communication ability as above. But could it be frustration? Is it frustration with their situation? And if it's frustration, does it hint that maybe they're recovering a bit, they're getting insight, they're frustrated at where they're at? Do they now have an understanding that, oh, well, I don't think I'm at the level I was before I came into hospital. I can't do the things I could do before. And whilst that in itself is not a particularly pleasant thought, it's a recovery in a sense that the patient is beginning to become aware of their deficits. And it gives us something that we can build on, particularly by bringing psychology on board. How do we manage it? So it's whether it's reversible or not. Realistically, for patients who are becoming very physically agitated and physically abusive, your benzodiazepines are key. But it's about managing safely. We don't want to over-sedate the patient who's impulsive, because they will still try and get themselves up, but they'll fall flat on their face on the floor. Ideally, if you can, trying non-pharmacological options first in these patients is your best bet. So one-to-oneing, a familiar face, even if the patient has an anterior grade amnesia, seeing the same person every day at some point is beneficial. Visiting, getting family in, getting family to see what's going on, family to potentially speak to the patient. Again, it's a familiar face. And psychology input for both family and patient. Mood, well, I hate to use the term, but post-traumatic stress disorder is very common in patients who've had a catastrophic brain injury. Patients will often describe reliving the events of their injury as their insight comes back. They often, particularly you have, and it's a newly documented phenomenon, post-ICU stress disorder, where patients remember as they woke from sedation holds or as sedation wore off, they may remember being ventilated, the sights, the sounds of ICU. Thankfully, it's uncommon. Patients with intact cognition, they might struggle with the functional issues. Attention and learning might be a source of frustration for these patients. They may, as we said before, they understand what their deficits are, but they don't see a way to get around them and address them. So educating patients where appropriate is key. We need to explain to them what's going on, and that's what our psychology team do. So going back to our patients, so you remember we talked before about the post-acquired brain injury cognitive window, 12 weeks. So we got to the September with this chap, and we were all a bit concerned because he's still demonstrating cognitive impairment at this point. So we brought the family in for routine goal setting because we finally could. They'd stopped us from doing that. We had to do it via Zoom. Oh, I think it was Teams for a while because obviously you couldn't have family visiting. So we managed to get the family in to discuss prognosis, but unfortunately they had some really unrealistic expectations. Dad's really intellectual. He's going to go back to doing what he did. You know, he's going to snap out of this. There's going to be a moment where he just wakes up one day and it's all going to be fine. And they're really common misconceptions that some people have. Commonly, people will say they're better off at home. There is some truth to that, but really it's like we said, we need to build a foundation to allow these patients to go back safely. We can't allow them to go back as early as some family members would wish. And it's only a matter of time until they're back to normal. This idea that they'll just wake up one day and they're going to snap out of it. It's, you know, it's a temporary inconvenience. It's not an issue. It's something that, you know, we'll just get past it. So what do they do? I mean, we have had a few medically inappropriate, you know, patients who discharged against medical advice, and they take the family take the patient home, and unfortunately we've got to fill the bed, so we take a new patient. They take the patient home and they try and continue as normal, and sometimes normal can be the patient goes home, they're left at home because the other half has to work. They've got 3 children under the age of 5 running around at home playing TIG, and they're making tea for everybody. And you can imagine that agitation that builds in that patient, being unable to focus their attention on 2 different things. They now have 2, in fact 4 tasks, because it's 3 children in front of them that they need to manage. The patient becomes overstimulated and unable to cope. So when they do that and family see perhaps they're not doing as well, family then could disengage gradually because they think, well, if I maybe give them some space, that will help. Or perhaps sometimes it's a case of, I don't know what I can do, you know, I'll wash my hands of this situation. It does unfortunately happen. So to try and combat these misconceptions, we have to try and speak up as early as possible. We unfortunately can't make guarantees, but we can tell people about the success stories that we've had and how patients do well, but they need to be given the tools to do well. So we've got to go through goal monitoring, goal setting meetings, getting the family involved early, home and access visits. So patient has, and thankfully now after COVID, we can do this. We can send patients back on a home visit. They can see what the home environment's like with the OTs present. They can do a trial run under a controlled circumstance, and then come back to the ward. Family and next of kin can learn to use the equipment, but before COVID, and I think now we are beginning to do it again, we've got some weekend leave booked, patients going off the ward from Friday to Sunday, experiencing what it's like at home, family understanding what they need to do. They get that equipment training at home whilst the patient's there, and bringing the family into the therapy sessions as well. So our case. So our patient was started on methylphenidate because he'd begun to develop some insight. His learning capacity was still in deficit, but we understood that if perhaps we could try and, as he still had issues splitting his attention, if we could find a way for him to focus his attention using methylphenidate, which is what children are given with ADHD in the States, Ritalin, then we could try and augment his learning capacity. His challenge of behavior still remained, but that was linked back to his false fixed belief about witches and druids and Wiccans infiltrating the ward. So back by the October time, we realised that our brain injury scoring, despite all of our intervention, had begun to plateau. We titrated up the methylphenidate, but it was having no effect. Attention sequencing in daily tasks and insight remained limited, but manageable in a set down environment. So he was now independently mobile. He was less impulsive. He wore his crash helmet as he was walking around. He was more safe. He had a set daily routine. He woke up at the same time. He was able to eat all of his meals. He was independent in washing, and he'd done his kitchen assessment. He'd managed to pass it. He'd done his road safety assessment where he'd been walked out around the grounds with the OTs, and he wasn't deemed to be unsafe. So we thought we'd progress into discharge as part of our plan. So we've got some progress in this patient, but what does progress really look like for the brain injured patient? Well, again, it's individual. It's not just the patient themselves, but his family will dictate progress. Sometimes you can have family who are really, really motivated and buy into the idea of rehabbing a patient. Sometimes you can have family who agree with the patient and say, no, I think it's all a load of rubbish. You know, you're making him do maths in his room. He never did that before he came in, so why should he have to do it now? I'll take him back. It's highly measurable with all of our direct deficit measurements, R-bands, PTA score, etc. But it's rarely predictable. All we can do is go off the picture that we're given. And that progress is often accelerated in the community. Really, you've got to hit the ground running when you get back. You've got to, unless you go into a nursing environment where there are few expectations on you, if you have to go home, you are likely to just do that a little bit better because you've got to adapt. But again, it's that strong base that we've got to give them. And patients with support are the ones who prosper. The ones who go home and have no one to go back to, who have no expectations on themselves, will deteriorate. The ones whose family will continue to do everything for them and the patient is quite happy to be a passenger will likely deteriorate. But those who go home and family have understood the remit of rehabbing and getting in touch with the allied health professionals out in the field and continuing with cares will do well. But again, it's highly circumstantial. So our case, so we're looking at discharge destinations now. So we're really fortunate in Hull. We've got some really good neuropsychiatric units. When we're discharging a brain injured patient, we have a few different places. So we can look at care homes, we can look at nursing homes, but for patients with whom we believe there is a further possibility of improvement and progress, we will look at neuropsychiatric units. Now, generally, these neuropsychiatric units were set up for individuals with complex cognitive impairment plus psychiatric needs. But now they are beginning to open up to our patients with just pure defined agitation and brain injury. So St Andrew's Care Partnership, Windermere, Marmaduke, Signet, to name but a few, specialise in neuropsychiatry in the area. But one of the things we're really fortunate for in the East Riding is SPHERE. Now, I can't quite remember exactly what it stands for. It's Specialist Psychiatric Health something, something, something. But it's run by one of the clinical neuropsychiatrists from the trust. And they go out there with specialized OTs, specialized physios, and they essentially give the rehab service in the patient's home. So, owing to location and cost, social services decided on Windermere House. And we were quite pleased with that because Windermere are very good. They offer a 6-month probation with a view to a personalised exit plan for the patients. They don't just tell them you're going to stay here indefinitely like some will. They want their patients optimised and home if they can. So when social services are looking at destinations for the brain injured patient, it's a joint decision between commissioners securing the funding and social services securing the placement, but they also need to make sure family are happy. There are multiple destinations that will work in this area, but the issue is cost. And the commissioners are not in the business of part funding. If a patient thinks, oh, if I give them some money, I can access a bit more, it's not going to work. You either get what you're given or you self-fund it. So they are a supplementary service after the patients go. Supplementary services that will help patients when they leave. So if they discharge home, we'll get community integrated care, SLT, and Sphere will even go to patients' homes for further, increasing the quality of their outcomes. But having things like Sphere and being able to commission them for patients, it's given us a bit more flexibility, and it means that some patients can go home where they may have gone to a neuropsychiatric unit previously. So I believe this is our last point on our case. So we followed him up in clinic in 2021, and by this point he'd actually gone home. He's now living at home with his wife and his son, and he owes this to a mystery procedure that happened in January 2021 as an inpatient. So have a think about what you reckon that could be. So he just immediately came in and apologised to our consultant and wrote us a card and said, sorry for everything I did while I was on the ward. I wasn't me. He's now living the retired lifestyle. He's stepped away from work. Unfortunately, as patients obviously sustain brain injury, they may find that it's less realistic for them to return to work, and particularly his work as an archivist and historian required a lot of record keeping and data upkeep, which was out of his remit upon discharge. But he continues to have input from Sphere. Because he's walked away, or because he's had to come away from his job, his mood continues to be low, but he is doing better. And he'll be seen in clinic every 12 months from now on. So let's see if you got it right. It was a cranioplasty. Now, it's really interesting, and there's quite a bit of information out there. I've put a paper at the bottom that I think is one of the highest impact papers around cranioplasty and improving patient outcomes. But really, the theory hinges on the patient begins to recognize themselves in the mirror again. They don't associate themselves with the person with the depressed skull who is injured. They see more of their pre-morbid self. They begin to recognize themselves. The data that's coming out suggests that earlier cranioplasty is better. Patients who have a cranioplasty earlier on will recognize themselves in the mirror. They will feel less self-conscious, less stress off the back of that, which means less splitting of attention, potentially less agitation. And also as well, don't forget, we're putting a bit of stress on the patients, because if a patient has an open flap after a craniotomy, we don't want them getting up and walking around, even if they're safe. We don't want them walking around without a helmet on to protect it, because if they fall forwards, even at no fault of their own, it can still be catastrophic again. So they don't have us harping on at them. And it promotes recovery through reducing that cognitive load and that stimulation. So how do we measure success? We can't hold everyone to the same standard as our patient. He went home and was a bit of a success story. But any recovery in any way is a level of a success for a patient. I mean, to who you know, who you're asking that to is a question. But really, I think maintaining perspective with a brain injury patient, enjoying little wins, following the journey along the way, and sort of reveling in the breakthroughs that you have are important. It's not just what the patient does, but also how they motivate themselves and how family motivate them at levels of success, because it shows buy-in from the patient, from the family, that they're onboarding the information that you're giving them. Seeing a change of their circumstances, going from a nursing environment to a step-down unit back home, that is success. And how patients adapt to what's going on, how flexible a patient can be, and how they travel along their own personal journey. So just really to round up, I think this discipline, particularly the brain injury patient, is about saving the person. It's not just saving the patient, but saving as much of that person as you can. You're trying to get them back to where they were and where they functioned. True brain injury recovery has to come from an MDT, and I've put a picture of some of our team up there from when we were based on Ward 9, when we got moved during the pandemic. We are fortunate we have OTs, physios, SLT in our building with us at all times. They're based in our building, they have an office in our building, so we're all together. If we need a patient, you know, if a patient needs to be reviewed, or if a patient is going to have their therapy, they don't have far to walk, and if they've got questions, you know, we're all on top of each other. You've got to recognise the type of brain injury and relate it to its location and function. Lobe level really is sufficient for this, but you know, don't forget neuroanatomy. You can dig through it and read as much as you want. It's all good learning. The consequences of brain injury may be multifactorial. You know, don't forget that frustration and fear may present the same way in agitation, but they're completely different mechanisms. And recovery, it doesn't have to take place on the ward, but we've got to give them a strong base to continue that care at a step down or going home. They just need sufficient support. So thank you very much for listening to me. I know it was a really long presentation, but I hope you found it useful. Does anyone have any questions?
Thank you, Tony. We'll keep an eye on the chat just to see if any come through that way. But if anyone has any questions for Tony, please turn your mic off and speak up. It's no problem. Can't see anybody at the moment that's got their hand up or anything, Tony. Would it be possible for us to share your presentation with members after this?
Yep, absolutely.
Brilliant, thank you. Thank you so much, everybody, for attending. We'll ensure that we share the slides. There will be a feedback form that goes out to you. We'll be really grateful for you to fill that in. Thank you so much for your time today, and thank you, Tony. That was a really fantastic presentation, really, really interesting. You've got lots of comments in the chat coming through, just thanking you and saying how informative it was.
Thank you all, and thank you all for your time.
Thanks, guys. Take care, everybody.